Hello and welcome. Today we're delving into Prader-Willi syndrome, a complex genetic disorder that impacts multiple systems in the body, but primarily affects the nervous system. It's a rare condition, but understanding it can make a significant difference in the lives of those affected and their families. Prader-Willi syndrome, or PBUS, is almost always by a genetic defect on chromosome 15. In most cases, around 70%, it's due to a deletion of a specific region on the chromosome 15. In approximately 20% of cases, it's caused by maternal uniparental disomy, meaning the individual inherits 2 copies of chromosome 15 from the mother and none from the father. Rarely, PWS can result from a mutation in the imprinting center on chromosome 15, which controls gene expression in that region. The underlying mechanisms of PBUS are still being researched, but it's understood to significantly affect the hypothalamus, a small region in the brain that plays a crucial role in regulating hunger, thirst, body temperature, sleep, wake cycles, and hormone release. The genetic defect disrupts the normal function of this region, leading to many of the characteristic features of the syndrome, particularly the insatiable appetite, metabolic issues, and developmental delays. Specific genes within the affected region on chromosome 15, which are normally active only on the paternal copy, are either deleted, silenced, or missing, contributing to the diverse range of symptoms. Prader-Willi syndrome is considered rare. It's estimated to occur in approximately 1 every 10,000 to 30,000 live births. The syndrome affects males and females equally, and there are no known racial or ethnic predispositions. Because it's a genetic condition, the risk is primarily determined by the presence of a specific genetic abnormality rather than environmental factors. The signs and symptoms of Prader-Willi syndrome vary with age. In infancy, affected individuals often exhibit hypotonia, or poor muscle tone, making them appear floppy. They may have difficulty feeding due to a weak suck reflex. As they grow older, typically between ages 2 and 6, they develop hyperphagia, an excessive and constant hunger that leads to rapid weight gain if not carefully managed. Other common symptoms include short stature, small hands and feet, mild to moderate intellectual disability, behavioral problems such as temper tantrums and stubbornness, sleep disturbances, and hormonal deficiencies like hypogonadism. Distinctive facial features, such as a narrow forehead and almond-shaped eyes, may also be present. Diagnosis of Prader-Willi syndrome is typically made through genetic testing. A DNA methylation test is often the first step, which looks for abnormal patterns of gene silencing on chromosome 15. If the methylation test is positive, more specific tests, like fluorescence in situ hybridization, or FISH, or chromosomal microarray analysis, are used to confirm the diagnosis and determine the specific genetic defect. Clinical suspicion based on the presence of characteristic symptoms, particularly hypotonia in infancy followed by hyperphagia in early childhood, prompts clinicians to pursue genetic testing. Prader-Willi syndrome is not classified into different types in the traditional sense. The genetic mechanisms that cause the syndrome, paternal deletion, maternal uniparental disomy, or imprinting defect, represent different ways the condition manifests at the genetic level, but they do not lead to distinct subtypes with varying clinical presentations. The severity of symptoms can vary between individuals, but this is more related to the extent of genetic disruption and individual factors than to any distinct classification. There is no cure for Prader-Willi syndrome, so treatment focuses on managing the symptoms and improving the individual's quality of life. In infancy, feeding support and physical therapy are essential to address hypotonia. Growth hormone therapy is often prescribed to improve growth, muscle mass, and bone density. Strict dietary management is crucial to prevent obesity, along with regular exercise. Behavioral therapy can help manage challenging behaviors. Monitoring and treatment of hormonal deficiencies, like hypothyroidism and hypogonadism, are also important. A multidisciplinary approach involving pediatricians, endocrinologists, geneticists, therapists, and dietitians is essential for comprehensive care. As Prader-Willi syndrome is a genetic disorder, there's currently no way to prevent its occurrence. However, genetic counseling is recommended for families with a child diagnosed with PBUS or a family history of similar genetic conditions. Genetic testing during pregnancy, such as chorionic villus sampling or anacentesis, can be used to determine if the fetus has PBUS, allowing parents to make informed decisions about their reproductive options. The prognosis for individuals with Prader-Willi syndrome varies. With early diagnosis and comprehensive management, including growth hormone therapy, dietary control, and behavioral support, individuals with PUS can live longer and healthier lives. However, they typically require lifelong support and supervision due to the challenges posed by hyperphagia, intellectual disability, and behavioral issues. Recent research is focusing on developing targeted therapies to address specific aspects of PWS, such as appetite regulation and metabolic dysfunction. Ongoing clinical trials are exploring new medications and interventions to improve the overall outcomes for individuals with Prader-Willi syndrome. The future holds promise for better treatments and a brighter outlook for those living with this complex condition.